Broadcast is now starting. All attendees are in listen-only mode.
Well, hello everyone. This is Güliz Barkan, broadcasting live from Maywood from Loyola University. I am the president-elect of the American Society of Cytopathology, and you are tuning in to our webinar Wednesdays. And today's guest is Ms. Donna Russell, who also doesn't need any introduction to this Cytology Society. She's a very well-known cytotechnologist and a very good friend. She is the education coordinator of the cytopathology residency and the fellowship training in the cytopathology laboratory at University of Rochester Medical Center. She also carries a bunch of other titles. She's the program director at Roosevelt Park Comprehensive Cancer Center, Damon School of Cytotechnology, where she gets the privilege and the pleasure to educate cytotechnologists. Now, she's also one of our executive board members at the American Society of Cytopathology, and those of you who have our Cyto-E conference, Donna chairs the Cyto-E conference committee, so you get to hear her once monthly doing one of our sessions just like this. She has presented at various national and international venues and published at a variety of journals. She's also the president-elect of the American Society of Cytotechnology. So what a bunch of titles, but what a wonderful person. And I am so excited to hear and learn about cell blocks and immunohistochemistry in cytopathology. Take it away, Donna.
Thank you very much, Dr. Barkan, and I'd also like to thank the ASC leadership and staff members for the opportunity to present cell block and IHC in cytopathology. The cell block offers many advantages over other cytology preparations, particularly for immunohistochemical stains and molecular testing. There has been an increased demand to obtain material for diagnostic, prognostic, and predictive purposes for cancer patients. Cell blocks of good quality and cellularity are essential for these purposes. This afternoon, we will briefly discuss specimen preparation types, including cell block techniques, and then I will present a number of cases via virtual microscopy. But before I begin, please answer a couple of demographic polls. The first poll is, I am a cytotechnology student, cytotechnologist, pathology resident, cytopathology fellow, or practicing pathologist.
If you could kindly mark your responses and we can read it. So looks like you have 44% cytotechnologists, followed by 33% cytopathologists, followed by pathology residents, 13%, followed by cytopathology fellows, and we have a couple of cytotechnology students with us as well.
And our next poll, do you work at a private hospital, city, county, state hospital, university hospital or academic medical center, VA hospital, or an independent laboratory?
All right, a couple more seconds and then we can show the poll. All right, it looks like most of our participants, 57%, are from university hospitals, academic medical centers, and then it's divided between private hospitals, city, county hospitals, and independent laboratories.
I'd like to just start with a couple of points of while handling specimens in the cytopathology laboratory. Patient specimen verification is essential, and as we've always practiced, we should treat all samples as infectious, especially in today's environment with COVID. Always wear appropriate personal protective equipment when handling these specimens. Our cytopathology preparatory technologists perform a gross description, including volume and color, as well as other comments on all incoming specimens. Cytology laboratories vary in preparation types throughout the world. We commonly perform direct smears, thin prep, and cell blocks on the majority of our samples. Thin prep preparation has become more automated with the introduction of the T5000 for non-GYN preparation. And I'm going to show you an example of a pleural fluid with metastatic lung adenocarcinoma on thin prep, diff quick, and cell block preparation types. SurePath or BD preparations also includes automation with centrifugation, aspiration, and decanting, and then transfer to the BD totally slide prep for completion of preparation and staining of slides. I want to thank my really good friend, Lisa Courtney Holmes, for all of the graphics that you're seeing in this presentation today. This is an example of a pleural fluid on a 79-year-old female and represents a high-grade non-Hodgkin's lymphoma, which had CD20 and BCL2 and 6 positive on immunohistochemical stains on SurePath samples and cell block preparations. The case was provided by Rochester Regional Health Cytopathology Laboratory. Thank you very much for donating this case for me to take images of. The cell blocks were introduced in the late 1800s using the colloidal medium, although the technique wasn't accepted really until the 1940s. Since then, techniques have evolved. Cell blocks can be performed on a variety of samples, and we all perform them on serous effusions and pelvic abdominal washes and FNAs, but it can also be performed on a variety of liquid-based samples. The procedure is applied if there's at least a visible sediment after being centrifuged. Just going to show you this busy chart. This table demonstrates some of the many advantages as well as disadvantages of a variety of cell block techniques. We've found that if you ask for dedicated passes, that most of these techniques will provide a really good cellular yield. Cost effectiveness and time are other factors to be considered, and it's important to find a method that works well in your laboratory. So on to my next poll. I'm interested in finding out what type of cell block does your laboratory primarily use. And I had to limit these to 5, even though I had 7 or 8 up there. So I combined a few of them. Number 1, plasma thrombin technique, agar or gelatin technique, colloidal bag technique, automated technique, which includes Celliant and the Shandon cytoblock, or the sedimentation technique.
All right, we'll give you a couple of seconds to give your answers, and then Joanne could show our poll. All right, interesting. Okay, so it looks like we have a 30% thrombin technique and 30% sedimentation technique, followed by agar and gelatin techniques at 20%, other automatic techniques at 15%, and colloidal bag is 5%, kind of on the lower side.
Okay, thank you very much for that. So we're just going to go through a few of the techniques. There's that not going forward. There we go. Many of the cell block techniques are similar, and most involve centrifugation. The plasma thrombin allows cell material to clot. The agar and gelatin is similar. It supports a concentrated sediment prior to tissue processing and embedding. The colloidal bag technique additionally uses agar or histogel to support sediment prior to processing in paraffin. The tissue clot technique is used often in our laboratory for our OR procedures. A clot is allowed to form on a glass slide before transferring it directly into formalin, and this technique we found prevents a loss of diagnostic material. There are some automated techniques. The Celliant is one of them. It's especially good for small tissue fragments. It is made directly from a thin prep file. It's automated, and the average time for each cell block is usually approximately 45 minutes. The Cytoblock system simplifies the preparation of a paraffin block from a kit and can be used for a variety of specimen types. And then it brings us to the sedimentation cell block technique, which about 30% of laboratories use. It's the lab that is most often, it's the type that's most often used in our laboratory today. And it's probably mainly because it's the least expensive and the fastest, because we prepare many cell blocks on a large number of our daily specimens. And we've found great success in this simple method. Here's just a few examples of some of the cell blocks that we've seen. The protocol for this, we allow the material to set in the formalin for at least 30 minutes to assist in hardening the cell pellet. Our cell blocks are cut at 8 microns, and immunohistochemical stains can be ordered up front to expedite sign out. We perform QA with 2 cytopreparatory laboratory technologists to ensure proper labeling. The cell blocks are placed in formalin for at least 6 hours, according to guidelines. I'd like to just, the next 2 slides demonstrate that cell blocks can be performed on samples with visible sedimentation. This first is a thin prep abnormal pap test. You can see that it's an invasive squamous cell carcinoma, and what a nice cell block we got from the residual in the vial. The second case is a urine bladder washing, and you can see we called this atypical. We did not see connective fibrovascular cores in the cytologic sample, but on the cell block you can see quite nicely that there's a fibrovascular core here. And this was a low-grade urothelial neoplasm, which turned out to be a low-grade papillary urothelial carcinoma on follow-up surgical pathology. So now we're going to get to the cell block unknowns. So let's start our virtual cell block unknowns. A variety of immunohistochemical stains as well as histochemical stains will be shown. And I'll give you all case histories. So let's get started. Case 1 is a 41-year-old male. He has a mass at the nape of the left neck, history of a skin disorder, and this neck mass was seen on ultrasound guidance. So you can see here on the diff-quick sample on 20X that there's quite a bit of cellularity. There's single cells. I think I see some mitotic figures. There's one right here. Again, there's a bit of cytoplasm, increased nuclear to cytoplasmic ratios. On Papanicolau stain, we see similar findings, single cells. And there's also some clusters of cells that were identified. Such as these groups of cells here with high NC ratio, prominent nucleoli, hyperchromasia. Cell block showed similar findings, mostly single cells with very prominent nucleoli and hyperchromasia and irregular nuclear chromatin contours. So we performed immunohistochemical stains, And I'll show that to you in a minute. So we're going to open up the polls to see what your interpretation is. There's only 4 choices here: squamous cell carcinoma, medullary carcinoma, melanoma, or metastatic adenocarcinoma.
Excellent question. So a couple of seconds, make your choices, and I'll ask Joanne to close the poll. All right, looks like vast majority is picking melanoma, followed by medullary carcinoma and metastatic adenocarcinoma.
Well, the answer was metastatic melanoma. Immunohistochemical stain shows that the cells of interest marked strongly with melon A, and I'm going to show you that here in a minute. You can see even on low power that these are picking up the melon A stain quite nicely. Here's the surgical, which demonstrates similar cells. Note the melanin pigments within the cells. So melanoma is a malignant neoplasm arising from melanocytes. It's primarily cutaneous, but also occurs in the eye, GI tract, and paranasal sinuses. It can be quite aggressive, and it's determined pathologically by the depth of invasion, the Clark's level, and the mitotic rate, as well as whether there's ulceration or erosion. And for immunohistochemical stains, we commonly will use Melon A, HMB45, S100 are all positive, as well as SOX10. This patient also had a follow-up pleural effusion, which was also positive. You can see here on Papanicolaou stain, the cells had high NC ratio with very prominent irregular nuclear membranes. The cell block contained, again, some very abnormal cells. It was hard to tell. Here's some normal mesothelial cells in the background, but some of these larger cells with prominent nucleoli were of interest, and this ended up being positive for metastatic disease. Here is the melanin A immunohistochemical stain on that pleural effusion cell block. So sometimes we have to think about clinical history in these cases for follow-up. Case number 2. This is a 74-year-old male. He has a 4-centimeter mass in the head of the pancreas. Weight loss and abdominal pain were the clinical symptoms for this patient. And this is the ultrasound, or the endoscopic ultrasound guided FNA was performed of this mass here. This is from a CT scan given to me by radiology with a nice red arrow pointing to the mass. So let's look at the glass slides. You can see that it's quite cellular. If I can find a better area, that's pretty thick. And we know on DivQuicks it's harder to see into these groups when it's so thick. Wait for that image to come up. So there's some abnormal cells here in the background. You can see high NC ratios, very irregular nuclear membranes. So it's an adequate sample. from the standpoint of this stiff-quick or modified Keims's stain. You can see the cellularity here on even on low power, how large these cells are. Papa-Nicolau stain. Shows similar findings. These are cells that are multinucleated. They're actually quite large in presentation. So we got a cell block on this, which was extremely cellular. You can see the cellularity here on 10x. How cellular this specimen is. And then high power, just to show you. The prominent nucleoli and irregular chromatin content. How bizarre some of these cells actually are. So some immunohistochemical stains were performed. And it was focally positive for AE1, AE3. And it was negative for CA 19.9 and CEA, immunohistochemical stains. So what is your interpretation in this case? Is it a ductal adenocarcinoma? Is it a metastatic melanoma? Is it a metastatic sarcoma? Or is it an undifferentiated carcinoma?
All right, the poll is now open. A couple of seconds for you to select one of the options. Like pretty poorly differentiated case. Let's see what it is. All right, Joanne, if you can share the poll. All right, so you have undifferentiated carcinoma at 58%, followed by ductal adenocarcinoma at 31%.
Okay, those are excellent choices. Well, on surgical pathology and our cell block, we thought it was an undifferentiated carcinoma on cell block, and surgical pathology follow-up, we had a bile duct margin excision, which was positive for involvement by undifferentiated or anaplastic carcinoma with giant cell features. And I think you can see here the tumor cells, and then again on higher power, showing these giant cell features. This patient, this is a rare tumor of the pancreas, and this patient had a follow-up Whipple, which revealed a 1.7 centimeter pancreatic head lesion that showed undifferentiated anaplastic carcinoma, and the patient ended up having 25 negative lymph nodes. So what's in the differential? As some of you pointed out, pancreatic ductal carcinoma, especially if they're poorly differentiated. And then some other thoughts you might want to think about are some metastatic lesions that have giant cell features, such as metastatic melanoma. We know it's a great mimicker and it can look like anything, as well as metastatic sarcoma, which you can see here. And as I said, pancreatic anaplastic carcinoma is a rare aggressive tumor. It accounts for only 2 to 7% of pancreatic tumors. It's quite rare. Has a male predominance, and it's usually located in the head of the pancreas, as this was. The prognosis is worse of that than ductal adenocarcinoma of the pancreas, and there's different subtypes. This was a giant cell, but you can also have spindle cell and round cell types. Okay, we'll move on to case number 3. This is a 40-year-old female who was a non-smoker. She had multiple pulmonary nodules, which you can see here on the next slide, which are nicely marked. Endobronchial ultrasound-guided FNA of the lung lesion was performed. And you can see here a large cluster of cells that don't look like they are probably bronchial cells, but let's go down onto higher power. Cells are quite spindle in nature, and then there's some large stripped nuclei here to the side. And then in the background, we saw other forms of really bizarre, wait till that comes up, really bizarre nuclei with some cytoplasm here. So with adequate sample, we knew we needed to get a cell block that we could perform immunohistochemical stains on. Here's the Papa-Nicolau stain. Again, on higher power, showing some of these cells with irregular nuclear membranes. Just move that away so we can see them. And hyperchromasia and prominent nucleoli. And we'll look at our cell block. Which shows some similar features in large nuclei. They're sort of oblong, maybe some intranuclear invaginations there, some wispy-like cytoplasm. Immunohistochemical stains were positive. This is the SMA, smooth muscle actin. And it was also positive for Desmond. As you can see here. So for case 3, what is your interpretation? Metastatic melanoma, metastatic sarcoma, a solid fibrous tumor, or a pulmonary hematoma?
All right, the poll's now open. Please mark your answers. A couple more seconds. And I'll ask Joanne to please share the poll. All right, looks like 75% voted for metastatic sarcoma, and the closest follow-up to that is solitary fibrous tumor.
Okay, for those of you who picked metastatic sarcoma, you're absolutely right. This is a young female patient who had a metastatic leiomyosarcoma. The tumor cells were positive for smooth muscle actin and Desmond, and they were negative for myogen and pancytokeratin. There was a soft tissue right pectoral core needle biopsy, which also showed a leiomyosarcoma. It's comprised of spindle cells arranged in a fascicular-like architecture. Leiomyosarcoma is a rare tumor derived from smooth muscle. It's the most common type of uterine sarcoma. There's a triad of histology features, which include severe atypia, increased mitoses, and tumor necrosis. It's usually a poor prognosis with these patients, and that's because there's limited therapeutic options. There's different histologic types, spindle, conventional, or epithelioid, or sometimes we've seen myxoid, and then some of the immunohistochemical stains that can be seen with these. On to our next case, moving right along so we can get through these. This is case number 4. It's a 75-year-old male. This patient has COPD and congestive heart failure. It was found that he had a PET avid right upper lobe lung mass. And this actually was my case. It was a bronchoalveolar lavage and a bronchiobrushing that was performed on this patient. The radiology I have for this, I have to credit the Centers for Disease Control. It's an example of a right upper lobe ball-like lesion in the lung. And we'll get to our glass slide review. You can see even on low power, the vast majority of the cells that are present in this lavage sample are macrophages. This is on 20x, and there's some inflammatory cells in the background. This is in the Diffquix sample. This was the only sample that actually had this entity in it. And you can see here, let me get this into the right corner so we can actually see. On cell block, very necrotic material, you can see here. Some inflammatory cells and some necrosis. See it a little bit better. I think there's some things lying in the background. I'm not going to give it away, but we did a silver stain and a PAS, periodic acid shift stain, on our cell block sample. Here's our silver stain. The patient had a concurrent transbronchial biopsy, lung biopsy, which I'll just show you. Wait for it to come up here in a minute. Okay. So, case 4, what is your interpretation? Is it an adenocarcinoma? Is it actinomycetes-like organisms? Is it an aspergillus infection, or is it a mucor infection?
All right, the poll is now open. And I must say, I love those beautiful pictures, Donna. All right, a couple more seconds for you all to put your answers in, and I'll ask Joanne to share the poll, please. Right, it looks like vast majority have called it aspergillus infection.
Well, they are absolutely right if that's what they called it. And like I said, on the lavage sample, it was just this one group that sort of triggered, oh my goodness, this is what we're probably looking for. It looks like aspergillus. And on the cell block from the bronchial brush sample, we did see some fruiting heads as well as septate hyphae. which sort of clinched that it's probably going to be Aspergillus infection. This is the PAS stain that we did. I showed you the GMS silver stain. Here's just another area with some really nice fruiting heads that look like sunflowers. Both were positive. And here's the right upper lobe transbronchial biopsy that was done concurrent, which shows, again, these nice fruiting heads and the hyphae, and very nicely highlighted on the GMS stain. The culture also showed septate hyphae that was consistent with Aspergillus in the culture sample. So what about Aspergillus infection? It's a filamentous fungus. It's found in soil and organic debris. Fungal balls form when the hyphal colonies collect in the lungs. It's dichomatous. It has 45-degree angles, as well as septate hyphae, where mucor could be in the differential, but it's more ribbon-like. There's fruiting bodies associated with the Aspergillus infection, which we saw quite nicely in this case. It's treated with corticosteroids or intravenous antifungal agents, and patients tend to do very well. And then the Grabcott methanamine silver stain, or GMS stain, we do perform a microwave technique, which is a modification of this stain in our laboratory. Our cytopreparatory technologists do all of our silver stains. So let's move on to case number 5. Case number 5, this is an 84-year-old female. She had a history of breast carcinoma years ago. She had abdominal pain, and she presented with 900 milliliters of yellow fluid, and this is an acidic fluid. By radiology, it was a loculated ascites that was thickened and had some nodular peritoneal involvement and some peritoneal enhancement, as well as some bowel obstruction. Let's look at the glass. You can see here there's a lot of clusters of cells. When we go on to higher power, you can see prominent nucleoli in some of these areas. This is the thin prep liquid-based preparation on this sample. There appears to be some vacuolization in some of these groups. When I go up to high power, you can see it a little bit better here. The cells are very hypochromatic, and it's hard. I guess here in the background you can see some side-by-side arrangement with some maybe normal mesothelial-like cells right here, potentially, and these. And then here's your abnormal cell groups that are clustering. And then on Pepinicolau, we do direct smears for our preparations for fluids. You can see this is our Pepinicolau stain material. It's very cellular, and I think you can see here it contains maybe some Pneumoma bodies. There's quite a number of these, but very irregular, sort of acinar-like balls of cells with prominent nucleoli and irregular nuclear membranes. I'm just going to show you the cellularity of the sample. You can see how cellular this is. It's one of those cases that doesn't require very many dots for the pathologist. And here's our diff-quick sample just to show you those same Pneumoma bodies are here, as well as the same features, irregular nuclear membranes and prominent nucleoli and some vacuolization. So in this case, we got a great cell block. You can see here groups of abnormal groups and clusters of cells with papillary-like configurations right next to your normal mesothelial cell architecture. And just another area where you can see those calcifications in the cell block also. So we did do some special stains. We did a BREP4. Which was positive, as you can see. It's highlighted here very nicely with our brown magic marker, as Dr. DeMay points out, calls immunohistochemical stains the brown magic markers. This is the PAX8. Immunohistochemical stain, which is a nuclear stain. And this is the P53 immunohistochemical stain, showing similar nuclear positivity. And she did have a history of breast cancer. So here is the GATA3 immunohistochemical stain. So what is your interpretation for this case, number 5? Is it metastatic adenocarcinoma of the lung? Is it metastatic adenocarcinoma of the breast? Is it metastatic adenocarcinoma of the colon? Or is it metastatic adenocarcinoma of Müllerian origin?
All right, the poll is now open. Looks like we know it's metastatic adenocarcinoma, but where is it coming from? And just a few more seconds, and I'll ask Joanne to close the poll so we can see what you all said. Looks like vast majority of you think it's Müllerian origin metastatic adenocarcinoma.
Excellent choice. That's indeed what it ended up being. We called it metastatic carcinoma. It's a high-grade serous carcinoma. You can see here the pneumoma bodies that were present and the papillary configurations. But with that history of breast carcinoma, we always have to take into consideration and do an immunohistochemical stain to make sure that that indeed is not positive. And in this case, the GATA3 was negative. Follow-up hysterectomy showed a papillary serous carcinoma, involved the mentum, fallopian tubes, ovaries, and myometrium. And you can see the tumor here. Serous tumors comprise 25% of all ovarian tumors. 30 to 50% are bilateral, cystic to solid. They have a variety of malignant potentials ranging from benign to invasive or malignant. And there's a variety of immunohistochemical stains that can be performed to help with the interpretation of this. Notice that we had the PAX8 and the P53 that were positive in this case. Let's move on to our next case. Case number 6 is a 76-year-old female. This patient had a history of weight loss and a 2-centimeter gastric mass. It was an endoscopic ultrasound-guided fine needle aspiration that we performed upstairs in the GI suite. So let's look at some glass slides. is different. Just scan and show you the cellularity of this case. A number of these spindle, really oblong-like cells in a bloody background. But it's quite cellular, as you can see, on low power. Higher power shows these groups of cells that are very elongated and spindle-like. So we got a really good cell block on this. Not much was present on the Pepinicola stain smear, probably because all of it went into the vast majority of it went into the cell block formalin container, because we knew we needed to do some stains, which we did. I'll show you the cell block and how cellular this was. You can see the cellularity of these spindle cells. It's everywhere. So we performed some stains. We performed an SMA. This is the C kit. My box keeps getting in there. There we go. So the C kit shows positivity, as well as the dog one. Which additionally shows positivity. So what is your interpretation on this case? Leiomyosarcoma, gastrointestinal stromal tumor, neurofibroma, or a leiomyoma?
Okay, the poll is now open. Give you a couple of seconds. What is the spindle cell lesion? All right, Joanne, could you close the poll? Let's see what we have. Looks like you got a whopping majority of gastrointestinal stromal tumor.
Well, that's indeed what this ended up being. Gastrointestinal stromal tumor with positivity for dog 1 and C kit, and SMA was negative. It's really important to differentiate between these two. As we know, the gastrointestinal stromal tumors, they occur in the stomach, the vast majority of these, but they can occur in the small intestine. Mostly they are submucosal, although some are subserosal. And we use CD117 or c-KIT as well as DOG1 for positivity, and CD34 can also be positive. There's a low risk to intermediate to high risk malignant potential. It's based on tumor size and mitotic rate. And there are targeted therapy drugs that are very helpful in these types of tumors. Gleevec is one of them. Okay, case number 7. This case is a 73-year-old male who has a 4.1 centimeter mass in his left hilum and mediastinal lymphadenopathy. This patient's a really heavy smoker, and we performed a lymph node station 7 endobronchial ultrasound-guided FNA. Just a little diagram showing these endobronchial ultrasound-guided FNAs, and here's the actual needle going through station 7 biopsy, showing the needle tip in this case. So let's look at some glass slides for case 7. You see here, it's quite cellular. It's an adequate sample. Has some high NC ratio, very limited cytoplasm in the diff-quick sample. Pepinicolau stain is very cellular also. With similar features. Not a lot of cytoplasm, very high NC ratios. Note the chromatin pattern. So we did a cell block on this case. Which was very cellular. And has some of the same features. High NC ratio, very crowded. We performed a few special stains. I'm just going to show you a couple because of time, so we can get through all the cases. This is a CD56. It's so light that I can't find my thing. There we go. Now you can see the nice positivity. And similarly, the synaptophysin, which you see here. So for case 7, what is your interpretation? Adenocarcinoma of the lung, carcinoid tumor, small cell carcinoma, or squamous cell carcinoma?
Okay, the poll is now open. And in a few seconds, I'm going to ask Joanne to share the poll with us. Looks like your vast majority is calling the say small cell carcinoma.
Well, they're absolutely correct. As well as the CD56 and the synaptophysin, it was also chromogranin and TTF1 positive, representing a small cell neuroendocrine carcinoma. And the key 67 showed a high proliferation rate. So small cell carcinoma accounts for 10 to 15% of all lung cancers, strongly associated with smoking as well as radon and asbestos exposures. There's usually male predominance. We went over the IHC profile, and these patients are treated usually with chemotherapy and or radiation therapy. Case number 8 is a 76-year-old male with a 4 by 2 centimeter mass in the body of the pancreas, experiencing weight loss and abdominal pain. This is the endoscopic ultrasound guided lesion, which you can see is somewhat lobulated in appearance. This is a 20x image of the cellularity present in this pancreatic lesion. You can see it's quite cellular. higher power shows these abnormal cells with higher NC ratio. And a moderate amount of cytoplasm. I'll just scan around just to show you the cellularity here of this sample. On Papa-Nicolau stain, we saw similar findings. It's quite cellular. And amongst this blood, you can see that there's a lot of cells present here. These little clusters of cells. And then on cell block, we can see similar findings with a moderate amount of cytoplasm. So we performed some stains. Performed a trypsin stain. Which showed positivity. We also performed a PAS stain, periodic acid shift histochemical stain. Which I'm pointing to some features here. And a PASD, which is a diastase stain, PAS diastase stain. And this reveals some diastase resistance. So what is your interpretation in this case? Is this an acinar cell carcinoma, a ductal adenocarcinoma, pancreatic neuroendocrine carcinoma, or a solid pseudopapillary carcinoma?
Okay, the poll is now open. Give it a couple of seconds. Beautiful images again. And I'll ask Joanne to open the poll, please, or close the poll and share. Okay, very good. 67% are calling this acinar cell carcinoma.
Excellent choice. This is an acinar cell carcinoma. It's a very rare type of lesion. The immunohistochemical stain shows that this was positive for trypsin, and the PASD reveals diastase resistant positivity. We did do electron microscopy just for teaching. In this case, it shows the presence of zymogen granules within the tumor cytoplasm, which supports that diagnosis. So acinar cell carcinoma is quite rare, only 1 to 2% of pancreatic malignancies. Has a low 5-year survival, only about 10%. And some of the differentials will include solid pseudopapillary carcinoma, and you can see it looks quite similar in this case of solid pseudopapillary carcinoma that we had, as well as the pancreatic neuroendocrine carcinoma could also be in the differential. Case number 9 is a 75-year-old female who was exhibiting weight loss, abdominal pain, and severe fatigue. And we only got about 75 milliliters of bloody fluid in this. It's a pelvic washing sample. So I don't have any radiology for this, so I'm just going to go right to the glass and just show you a couple of images. This is the Pepinicolau stain. I'm going to show you this because I want to show you that there's beautiful sheets of mesothelial cells. Beautiful sheets of mesothelial cells that you can see here in the background. And then right next door, we were seeing these clusters of cells that, you know, we were thinking, this is a tough case. Are these just mesothelial cells, or, you know, is this something worse? Because look at this prominent nucleoli and increased nuclear to cytoplasmic ratio. I think everybody has these cases sometimes that we're just not sure of. So we did do a cell block in this case, and just show you that. I think the cell block makes it a little bit more obvious because you can see the nice mesothelial cells as well as the tumor cells here. You can see here's the tumor cells. I can find it. It's a little bit easier to see on lower power. You see the tumor cells here, and then your nice sheets of mesothelial cells. So we did some stains. We did a Mach 31, which shows that it's indeed a malignancy. I think it'll take a minute to get that up, but you can see how positive this case is. And we also did a CDX2. Which showed some focal positivity. You can see here. We also did a Kreiberg, which is a mucin, a stain for mucicarmine. And I like this a little bit better than the mucin stain because you can see the mucin within these cells is a nice robin egg blue color. And you can see that it's picking up that. Let me just move this box to get it a little bit better. You can see the nice robin egg blue from the mucicarmine stain, or from the Kreiberg stain, which is positive. And in this case, the patient has what? Benign mesothelial cells, metastatic adenocarcinoma from the breast, metastatic adenocarcinoma gastric, or metastatic adenocarcinoma of the lung.
Okay, let's share the poll. Looks like 78% are picking metastatic adenocarcinoma gastric primary.
That's absolutely correct. I probably shouldn't have shown you the CDX2, or it gave it away. In this case, this patient had actually outside slides that were submitted for consultation at the same time, which showed a poorly differentiated adenocarcinoma of the stomach in a biopsy. We know that gastric adenocarcinomas can be quite aggressive. The average 5-year survival rate is only 10 to 15%. It's the second most common type of malignant tumor, but it is declining in the United States, and it has a male predominance. So let's go to the last case of the day. 48-year-old female. She had a history of cervical intraepithelial neoplasia as well as a squamous cell carcinoma of the anus. And we received a pleural fluid on this patient. 800 milliliters of amber fluid was received in the cytopathology laboratory. So this is the thin prep of the pleural fluid. I'll go up on, that's 20x objective. I'll go up onto higher power. You can see there's all these clusters of cells, some vacuoles, some prominent nucleoli. And then on the diff-quick, similar findings, you can see it's quite cellular. Let me just get this to the edge. You can see it's quite cellular. Again, similar findings, very high NC ratios and a lot of vacuolization as well as hyperchromasia and irregular chromatin material. The cell block demonstrated similar findings, these ball-like groups of cells. You can see. On high power, you can see the irregularities, some vacuoles, some really balling up of these groups of cells. So we did some stains, and I'm not going to show all of them. I'm going to see how you do without all of the stains. So this is the calretinin, just showing you the benign mesothelial cells in the background. You notice the tumor cells are not picking up the stain, only the benign mesothelial cells present in the background. So a nice internal control for your calretinin stain. And I will show you one more. The TTF1 was also negative. And I think I probably can show you the Kreiberg stain, which is also negative. So negative Kreiberg, negative TTF1, and negative calretinins, just picking up the background stain. And the next stain is positive, but I'm not going to give that away. We're going to, you can see how positive it is. We're going to go to the poll. What is your interpretation? Metastatic adenocarcinoma of the breast, metastatic adenocarcinoma of the lung, metastatic adenocarcinoma gastric, or metastatic squamous cell carcinoma?
Right, the poll is now open. And we'll give you a few seconds to finalize your answers. And I'll ask Joanne to share the poll, please. Okay, looks like you have metastatic breast adenocarcinoma and metastatic squamous cell carcinoma against each other, but breast carcinoma is 44, the other one is 38. So let's see what you have.
Okay, this was quite an unusual case. You know that those cells are balled up. This actually turned out to be a metastatic squamous cell carcinoma. The immunohistochemical stains showed positivity for P40 and cytokeratin 5-6, and they were negative for TTF1, NAPSINA, GATA3, WT1, cytokeratin 7, and 20 stains. And I'll just show you again that P40 stain, which you can see is really positive. It's a nuclear stain, and it's picking up that positivity here in many of the nuclei, almost all of them. If I move this out of the way, I don't know if I can move it. Okay, we'll go back to the PowerPoint. This is the patient's anal pap test. I couldn't find the biopsy to take a picture of it, but we thought this was a high SIL, more serious not excluded. The patient ended up having a squamous cell carcinoma on anal biopsy. I think all I have today, just to remind you the risk factors for anal cancer, squamous cell cancer, smoking, HPV, HIV, lower immunity, increased sexual activity, and fistulas. But anal cancer treatment really depends on the stage and level of extent and involvement, whether it will be resection, radiotherapy, or chemotherapy. And the squamous markers will be positive in these cases. That's all I have for everyone today. Are there any questions? Sorry, we went over a little bit.
That's okay. That's okay. That's totally fine. So thank you very much for this vast array of cases. My goodness, and such beautiful pictures. So I must say on the question board, the participants are green with envy about what kind of method you use for your cell block and why are your cell blocks so beautiful. Tell us about it.
Well, I'll tell you what we do is we ask for dedicated passes. And, you know, sometimes when we're up in the endobronchial suite, they'll give us 7 dedicated passes for a cell block. You know, sometimes they call us greedy. You know, I've been called greedy before. I look at the specimen. We actually look at the specimen to determine whether or not there's enough in there to spin down. You can visibly see when you do get a really good cell block, you can see it. And we go right into formalin for our cell blocks. Now we used to use saline, but we no longer do that. We use formalin fixation directly in the OR and pulmonary suite, GI suite, and down in our other cancer centers. So I guess dedicated cytopreparatory technologists also downstairs, our prep girls are amazing. They get cell blocks from little or nothing. They may spin down 5 or 6 tubes of ascites fluid to get a really good cell block. We have our cytopreparatory technologists have been here for a number of years and they have vast experience in this. So they do a fantastic job. So I guess those are the 2 reasons why, and we use a sedimentation technique. It's fast, it's inexpensive, so the hospital likes that.
So you're not using a thrombin or agar technique, you're just sedimenting it, you're spinning it down, correct?
Just spinning it down, and sometimes if it doesn't clot up, we will use formalin to harden it, but we'll spin down multiple tubes in order to get, you know, a nice cell pellet for a cell block.
So for instance, if you get 1,000 liter of a pleural fluid, what do you do? What do you use all of it? Do you aliquot from it? What is your methodology?
They shake it up and then they will pour 2 conical 50 milliliter tubes and centrifuge that and see what they end up with as far as the cell button goes. If they need more, they'll try more, but they start with just 2 50 milliliter conical tubes. Generally, most fluids will give us at least something to work with, and it's usually a pretty nice cell block.
Mm-hmm. There's a question about validation, and this always becomes an issue, especially if you're collecting it in media other than formalin. But let me ask you both of these questions from one of our participants. So since IHC validation in histology lab are done on formalin-fixed paraffin-embedded tissue, how do you validate IHC positivity and negativities on cell blocks? Do you have a separate validation for cell blocks, or do you just use the surgical pathology validation?
Well, we did do a validation, and I didn't include it here, but we took cases off the surgical bench, and we looked at, I think, over different types of immunohistochemical stains. We made a cell block from the specimen, and we also had the surgical as the gold standard. So we did perform immunohistochemical stains on both.
On both cell block
the
and
cell block at that time was put into saline, what we used to do, and spun down immediately and then placed in formalin for at least 6 hours. But now we go right into formalin fixation. So we have validated it through formalin fixation. We don't use saline anymore, but we did do a validation to make sure that that worked, and we had 98% concordance with all of our stains. So it worked very well. But you do have to validate if you're using something other than formalin fixation, and your laboratory should do that because there can be some differences, especially with alcohol fixation or saline. You may experience some differences in immunohistochemical stains between the two.
Correct. Okay, so next is for molecular testing. What is the best cell block method for molecular testing? And this has been a big issue. It has been on the ASC listserv. There has been recent publications on this, about using some of the cell block techniques interfering with molecular tests. What is the feeling on that? What do you think?
Well, I think I read a article back in, I think it was from 2016 or 17. Dr. Roy Chowdhury was one of the authors that said that cytology specimens were a gold mine. And in the article, it said that actually specimens that are fixed in alcohol are some of the best for molecular extraction. So I'm thinking that's probably the case, but those of us who use formalin-fixed cell blocks, I think we've shown that if you get a really good cell block, that you could do molecular testing on those specimens, such as PDL1. We did a study a couple of years ago looking at PDL1 in cell blocks versus surgical pathology as the gold standard, and they paired equally as well in the majority of cases. I think it was over 95%.
Mm-hmm. So I think bottom line is, although maybe ethanol fixation might be good in certain instances, formalin fixation would be better to make sure we are able to do our immunohistochemical stains, and perhaps if further molecular studies are needed, then it still could be done in formalin fixed paraffin embedded tissue.
Right. We try to preserve as much as we can and only order the stains that are needed. Sometimes we'll use double stains in order to do that, so that there's a material left in the cell block so that we can perform those molecular studies. But we try really hard to get, great cell block material so that we know that immunohistochemical stains as well as molecular needs to be performed.
There's a question about immunohistochemical controls for cases. So do you get positive controls or negative controls for your stains on every case, or do they, in your laboratory, do they run it per run, like one control, positive and negative control per run?
We get it usually for each stain. Sometimes it's on the same slide. Other times it's on a separate slide.
So
it depends
on
the cell block, I think.
So you get it per case, okay.
Per case.
Another question about the methodology. Have you tried primary formalin fixation on fluid sediment, recentrifugation, discarding the formalin, and then fixing in alcohol formalin?
We have not.
You have not, okay. I think this was, again, primarily for IHC purposes. It was one of our participants asking that question. Another question is, again, one of our participants is asking, how do you get your histotechnologist not to face off the block or cut so much into the block such that nothing is left on the block afterwards? Do you have a protocol for that?
They do downstairs in histology. They try to preserve as much as they can off the cell blocks. The cell blocks are cut at 8 microns. And like I said, if we know up front that we're doing immunohistochemical stains, they will go ahead and do, I think it's 9 separate cuts in a row for that case, so that they can be used directly for IHC and or molecular testing. And we have those in the file ready to go. And if they're ordered by noon, they can be out the same day.
Oh, very good. Very good. Excellent. Well, thank you so much. This was very nice, and it's good to hear from someone like you who has, worked on this very hard. And clearly in your laboratory, things are working very nicely. You have beautiful cell blocks. So if anyone of the participants have any other questions, I'm going to refer you back to Donna to ask about methodology. But unfortunately, we are up on the time. So I'd like to thank Donna very much for this beautiful lecture and volunteering for the ASC.
Thank you, Elise.
Sure. And thank you all for joining in our Wednesday webinars. It's a pleasure to have you all and be together to learn more about cytology. So next week, same time, we'll be listening to Dr. Chuck Sturgis from Mayo Clinic, and we'll be learning about CSFs. Till then, stay safe and be well.
Bye, everyone.